Hello and welcome to this week's TechTO Health online. We are so excited to have you here and to have you join us again this week. We do this every single week from 12 to 1 on Thursdays. And I'm going to just do a little bit of housekeeping, and then we're going to dive into the special presentation that we have this week from Will Falk. My name is Maggie Bergeron. I am your community director at TechTO Health. And our mission is to bring together the healthcare practitioners, healthcare communities, and health tech community. So we would love to know who's joining, and you can let us know by going over to the poll section on the right-hand side of your screen and filling out that poll. Are you an implementer? So those would be healthcare practitioners and organizations who use technology on a day-to-day basis. Are you an innovator? So are you creating tech or an innovative solution? Are you both, other, or not in healthcare at all? So go ahead and vote or put your poll in on the right-hand side of the screen. Today we're doing something a little bit different. So the past weekly events that we've had have been panel discussions, but today we have Will Falk here, who's going to do a special presentation, as you can see on the screen here, and he's going to be talking about virtual rules. We are going to be listening to this presentation until about 12:45, and then we will do some Q&A and then head to networking. We would love for you to be social by both putting in your comments and your questions in the chat, and you can do that anytime during the presentation, and for you to share this on LinkedIn using the hashtag TechTO. So if you open up LinkedIn and just share that you're in this presentation, share something new that you've learned, or maybe somebody new that you've met, and just make sure to use the hashtag TechTO. That would be fantastic. And let's get into it. So welcome, Will. Thank you so much for joining us. Will Falk is a retired guy, as he's described it to me, who spends time at CD Howe and Rotman, and also advises many startups and has many different roles, as you can see on his slide here. So he's worked in tech and health tech in a variety of different roles, and we're very excited to have you here and to share your presentation and your thoughts with us. And I'll hand it over to you, Will.
Thanks, Maggie. I really appreciate it, and thank you, folks, for coming and listening today. It's nice to see some friendly faces in the list of folks there, and also to meet some new. I want to acknowledge one of my colleagues, Carson Rorai, who is in the audience and helped me develop some of these slides. I am on rural broadband outside of Orangeville, so if I have problems, someone's going to tell me, and we're going to figure it out. I'm going to base the talk today on 3 recent publications that we developed at CD Howe and at the Women's College Institute for Health Sustainability and Virtual Care. The first of those was published back in 2018, well before COVID, and talked about modernizing Canadian health system through virtualization of care. Since that time, we've been writing a little bit about what's happened with virtual healthcare and the rules that will be needed as we move forward. Those citations are here. I'll note that my talk is already posted on LinkedIn and Twitter. You're welcome to go and pull it down. And if I'm moving too slow, you can move forward in it for me. Okay, I'm going to hop right in. In our last April paper, we identified 5 areas in which rules are going to be needed, and those are listed here. They include the obvious around patient safety and quality, privacy and security. Also things like the billing considerations, utilization impacts. There's a team of us who are kind of actively studying these issues and looking at them, and we'll have another paper out through CD Howe probably in June at about 8,000 words covering a number of these issues. I'm going to introduce a couple of concepts up front to talk about those issues, and then I'm going to dive into the issues. I'm assuming by the silence of my colleagues that I don't have any problems at this point from a technology point of view, so I'll just keep driving. I want to introduce a framework that we're calling costs of physical contact. COPC is not just a healthcare framework, but is the idea that for the next, let's call it a year and a half, the higher costs of physical contact will act as a disruptive force and allow new production models to come in. That's obvious today as we're working from home, et cetera. I believe that that will be the case for at least the next 12, 18 months, and that will then adapt in a new normal. For those of you familiar with Clay Christensen and his work, you'll recognize that disruptive innovation is usually thought of as a cost-based item. And that's why we're calling it costs of physical contact. The idea being that new solutions are needed to answer the new attribute, and that as those new solutions are developed, we have a good enough production models that then flip in. Now, today I'm going to focus on virtual care. I will say to you that this is happening in every single industry. If you go through industry by industry, I don't care whether you're talking about cinema or travel, education, justice, every industry is dealing with this notion of costs of physical contact and dealing with things and how they go through it. The second point that I want to introduce that's a conceptual point, if I could make this work, is that virtual care is happening differently than we thought it would. So for those of you who are familiar with our earlier work in 2018, and in fact, Sasha and I have written papers back since the 2011 fee negotiations, we always assumed that virtual care would reach a stable point of about a third to a half, but we assumed that we would approach that from the bottom, that it would be a slow slogging through the swamp to get through 5, 10, 15, 20% up to a 1/3, 1/2 virtual mix. And of course, what has happened is that the system flipped on or about the 15th of March. And most healthcare systems on the ambulatory side are already between 60 and 80% virtual in terms of their interactions today. And so that different adoption path, obviously driven by the cost of physical contact that I've already spoken about, means that the questions we're asking are different than we thought we would be asking. We're asking questions about how to stabilize, how to bring rules in on a system that's already gone to virtual care. Now, it hasn't gone to virtual care in a terribly sophisticated way, and I'll come back to that. But it is a virtual system at the moment, and it has to be stabilized, and rules are needed. How quickly has it moved? Well, here are the recent numbers from the Commonwealth Fund. I don't know if everyone on the call has seen this. These are US ambulatory care data by specialty. Between mid-March and mid-April, 60% was the decline in the ambulatory visits. That moved online on a much lower denominator. Here are the Canadian numbers. This is from an InfoWay presentation that I grabbed a screenshot of. You can see that in Canada, in 2 recent 1-week periods, 60% of healthcare visits were conducted virtually, and about 40% were in person. And you can see the split by modality, which is pretty interesting as well. A lot of people kind of make the mistake of calling virtual care telemedicine. And it isn't that. Virtual care is at least a half a dozen different modalities, of which video is often the least popular. And I think I know there are a number of providers on the call who can explain in more detail than I can why they hate video as a modality. Maybe that's a surprise to no one. Video is a very difficult modality, as I'm proving right now on Hopin, speaking to my screen. Okay, so what's going on? Well, the first thing we did was stop, and then we moved to Zoom and call. And when I say Zoom during this presentation, I really mean Zoom, FaceTime, Google. I actually, in some ways, don't even care. Telling you that I'm talking about Zoom is like me telling you that I'm calling you on a Rogers cell phone. It's just a way of getting to you, and it'll stabilize fairly quickly. Inpatient volumes are down by 30%, ambulatory down by 50% plus. Most clinicians are having big problems because they can't get OR time, they can't do treatments, diagnostics and procedures are all deferred. Many physician incomes have completely crashed, and fee-for-service providers are down about 50% on the revenue line. When the May 15th OHIP payment hits, it's going to be really upsetting for a lot of people. There's a lot of bankruptcy risk in the system. We don't think about that, but a lot of these are structured as small businesses, and many of them will be bankrupt if they don't figure out solutions to virtual. The risk of a second wave remains very high. The CDC and others have talked about a November second wave bigger than the first. I'm not expert in the area. I just read what others say, and it seems obvious that it will be a factor. I don't mean that it'll be an overwhelming factor, but I mean that it will be a factor for at least the next couple of years. We still haven't, the last point there, we still haven't differentiated amongst COVID and non-COVID facilities. There's a whole set of possible solutions, and most people in their practices are dealing with those solutions. What can we deliver virtually? How much can be delivered safely at scale? How do we mix virtual and physical? I'll give a couple of examples. A number of surgeons who I know are looking at how they do their pre-op and post-op visits virtually so that they can start cutting again. Cardiologists I know mix their stable populations. So these are people who have a history of heart failure or arrhythmias, and they're on a 6-month cycle. Those people are staying virtual, but the symptoms are coming in physically, and then the waiting room is set up in a way where that's one patient at a time. There was a good example on the web recently about a well baby course of care where months 1, 3, and 6 were moved to virtual, but 2, 4, and 12 are physical. It's very important that we be able to mix virtual and physical, in part so that we can keep the physical space safe for those who need it. So virtual isn't just a solution in and of itself. It's also a solution that makes the physical work so we can have things like JIT, just-in-time waiting rooms, so that we can have clean surgery centers and clean hospitals and ambulatory care facilities. Now, Maggie, I know you're dealing with this a bunch, right, at Embodia, because you guys have, I mean, physical therapy is an area that's got to move out of being physical and be physical therapy that's not physical. How's that working for you? Okay, this is where you have like this terrible feeling that you've been talking to yourself for 15 minutes? Yes, no? Okay, so Maggie and I were surprisingly talking to this friend, so I know that we're speaking now I'm going to assume going in the chat that I had, that Maggie, you're up. You're in, Maggie? Okay, thanks, Duncan. I appreciate that. So I'm going to keep going, and let me make a couple of other observations about the situation and how it's working. By the way, I think I just proved again why video is such a lousy goddamn modality, and one we need to rethink and get away from as soon as we can. Look, in our 2018 paper, we put a 10-step checklist together. And before I do anything else, I want to point you back to that paper and that checklist and talk about the 7, maybe 8 of those things that really need to be still done. They're pretty basic foundational pieces. Is that you, Maggie?
I'm back.
Hey. You want to tell me a little bit about how Embody has been adapting and what's been happening in physical therapy as an example?
Yeah, absolutely. So when the pandemic hit, we launched a virtual care platform, which was included in our membership. And it makes a lot of sense with what we were already offering in terms of digital patient engagement and exercises and education. And we were shocked and overwhelmed by the response and the growth that we experienced just by adding that in. There were certainly a lot of early adopters, and then we've had some trickle in afterwards when they realized that the pandemic was going to go on for longer than 2 weeks, and they had to close their physical doors, but there were other ways that they could provide care to patients. Of course, in physio, a lot of the discussion is that our training is a lot about our hands and modalities that you really do need to be in person for. But the research of why patients get better actually indicates that a lot of it has to do with speaking to patients, counseling them, giving them education and exercise, not so much what we do with our hands. What's powerful is what we do with our ears and our mouth.
Yeah, and I think a lot of us are relearning our crafts as we do them. And adapting. Again, I'm not just making a health or medical comment here. I think we're all learning different ways to deal with one another. I've had friends who've put church services online. I've seen one not-for-profit board that I'm on where I wouldn't think that before this started more than 3 or 4 of the people on that board had ever done a virtual call. Now we do virtual board meetings all the time. This is a society-wide thing, but to do it well in healthcare, we need some basic infrastructure, and that's what's on this slide. It's the regulatory colleges need a secure email for everyone. We need on-call services that work on virtual care. We need email inquiries to be able to work, and we need the funding system to reflect the fact that synchronous and asynchronous virtual are important. We need to make a clear statement that results have to be digital and that it's simply unacceptable to not produce results and forms in digital formats. It's not actually reasonable to ask someone to fax you a document back, or even these days to print a document and fill it in. You have to provide them with a form that can be filled in. And I can tell you, in recent weeks managing family members' care, I've had people ask me to print out forms, hand fill it in, and fax it to them. Well, sorry, folks, I don't own a printer. I'm not alone in that, right? Email and the telephone use, actually answering phone calls, and then thinking through what the ministry used to call digital health by design, which is the idea that, we need to think about courses of care and how they work. Anyway, those are practical steps. Let me talk a little bit more about the COVID stuff and some stuff we can do in COVID. First, I want to talk about congregate adult living, long-term care, retirement home. We need to make population health a reality. And there's been a lot of work that's been going on this, but the idea that someone is responsible for helping the home when they get out of green into yellow and red, and how we do that. Now, I'm going to leave for the public health officials the question of how we manage the yellow and red one, but I want to talk a little bit about how we manage homes in the green. And my premise here is that retirement home and long-term care homes generate a lot of specialty care, including physiotherapy and other care, but those people aren't going to be allowed to leave their homes for quite some time. So the question of how we organize our specialty clinics so that we can provide the needed chronic complex care on an ongoing basis for the next 18 months into long-term care is something we have to think about. We cannot simply order the long-term care patients to come into our hospitals. There is no one-size-fits-all solution. The segmentation of virtual tools, I threw up the old Watches slide on healthcare cost concentration. I'm sorry, this is a bit of inside baseball and I apologize for it. But what it talks about is the segmentation in the healthcare system, the 1% accounting for a third of spending, 5% accounting for 2/3 of spending. The idea that there's one virtual solution any more than there's one physical solution is not right. We need to have different circle of care technologies. And I'm going to switch here to a bit to the technology side more specifically and talk about how the tech could and should develop. This is a schematic of our old EMRs. Basically, they were filing cabinets that recorded the visits and the results of the tests sorted from the face-to-face visits. They generated bills, and then if we needed to communicate with someone, we sent faxes. And unfortunately, in many practices today, this is very much the reality. What has been forced on us is a set of virtual services, largely the phone, some Zoom, and more sophisticated practices, text and email. Up the sophistication chain, there's self-care and monitoring. Often that's disconnected. And finally, there's circle of care and clinical messaging and orders, which I think you're starting to see that in things like orthopedics practices, some of the work that Ocean and others have done. Input Health has some stuff. Arguably, the e-referral stuff and e-consult stuff is this. The point is that communication stuff over on the right is now where the action is, and you can't simply do a face-to-face visit and then deal with communications. Now, records or communications in a system where you're building tech that's just records, you're taking a database data storage approach. In a place where you're building comms tech and you're building communications tech from the ground up, the record as such becomes exhaust from the communications protocols. But the job to be done is quite different depending on which approach you have. And I'm just going to make the point again. The older tech was built this way. The newer tech will be built from the right to the left. It will be built on the communications first and then lead to a record of those communications and billing. And you can see that in the new tech that's coming on. Now, of course, we've got all the old tech that we need to bolt on stuff to. And so everyone is bolting on right now, right? And so you see these Frankensteins of Epic and Zoom that are being done. I shouldn't call them Frankensteins. It's a perfectly reasonable solution. Almost every vendor now has a virtual care product of some kind. Some vendors have 4. The more modern products include at least 3 of the modalities on the left-hand side. A few include all 7. And having a multimodal system is really, really important. You see Think and Point Click Care. You saw the Infoway announcement where I think they subsidized 12 certified vendors. I said this earlier, but I'll say it again. Video will be a commodity tech soon. The fact that we're on Hop-In today, who cares? We could be on Zoom, we could be on whatever. The sophisticated products will link the modalities to the filing cabinet and billing functions. It's not clear to me that the record function beats the communications function. If you look in nearby spaces, if you look at companies like AlayaCare and Home Care, building out communications first rather than trying to integrate to 1990s tech may be the way that this goes. Or to put it more pithily, why would I integrate to that stuff? Now, I'd say that not to throw out the old tech, but to introduce the question that this idea, and I'll go back up a slide. It's the first time I've done this talk, so I'm kind of jumping around. I apologize. I'll go up and I'll just say, records or communication, where do you start and how do you build both together? It's not clear to me that the records are where you would start, so long as you couldn't generate a bill while doing communications that includes a record that's good enough for the college. I kind of want to pause and take questions there, but I'm not going to. I'm going to go on to one more topic or 2 more topics and then close. I think I'm doing good on time. I am. Payment reform. This is really needed. The government needs to get out of the way of the choice of modality. Paying for stuff, which is what fee-for-service is a really crappy way of paying for healthcare. The way we want to pay will have to vary by the type of bundle and the type of service. It goes by different names. There's a couple of slides in the appendix that you can review. Complex chronic bundle payment. What's driving the slowness on government or the past slowness, because I really do want to give the ministry a lot of credit for having moved so quickly on the K codes, is the lack of, they're really afraid of churn on asynchronous codes. Asynchronous codes are relatively frictionless, would be relatively frictionless. And they're really worried that people will then generate a whole bunch of email traffic and bill for it. I don't think that's going to happen. I don't think most people will do that. And I think that those who will can be managed. But I think that's what's, as a former negotiator, I can tell you that that's a part of what's driving it. But I do think the ministry has some good policy options, and I'm hopeful that the ministry and the medical associations will sort this out. I'll close by saying that, as we said in the 2018 paper, the quadruple aim should really be guiding what we do here. We need to talk about the all 4 of these items. We talk about improving the population health. We talk about reducing care costs. What is becoming clear with the higher costs of physical contact is that it's critical that we look at how to improve satisfaction and access for providers and for patients. We can't expect them to come through these tough times without some thoughtful workflow measures on how access is working and how we're going to make life better for these people. So as we push that denominator back up, as we get the revenue line back up and start delivering more and more stuff virtually and in safe physical environments, we need to keep the quadruple aim in mind and think about that as we go forward. And Maggie, I'll stop there and we can have a bit of a discussion.
Fantastic. Thank you so much, Will. There are questions. And for everybody who does have a question, please just post it in the chat and we will get to as many as we can. The first question is from Nicholas. How painful do you expect it will be to move the data from legacy systems into what people are building now?
It's an interesting question because, and again, I'm going to oversimplify the Alaya example, which of course, Alaya is now Canada's most successful home care company, having bought their number one legacy competitor in the last 6 months after raising a Series C of $53 million from the Case to Date poll. And what they did was to build mobile first tech for PSW and mobile nurses, which doesn't sound like a blinding insight. But the old tech had all been built on PCs, and people were always taking the same point of view that this question takes, which is that we would, innovate from the old tech. Well, as anyone who's done software design will tell you, sometimes that's not the easiest answer. And, my friend Steve LaHaye runs a billing operation. I have no commercial interest here. He charges 10 cents a bill to do OHIP bills, right? It's a commodity tech. I'm not sure that the medical record piece of this isn't easier to do than the comms piece. So I'm not sure, maybe I misinterpreted the question. Can you read it again, Maggie? Where was it? Oh, there it is.
Yeah.
How painful do you expect it to be to move? So actually, maybe I'll reinterpret that, because if what we're doing is just moving the data from legacy into new systems, I am told by a couple of vendors in the space that they've got solutions for that. I think what's going to happen here is that the legacy players are going to have their own bank accounts used against them. So they've set a bar. I think, what was Accuro purchased for? Does anyone know offhand? I'm going to say $24,000 a doctor. And the previous ones were all in the kind of $10,000 a doctor basis. So I'm going to say the conversion costs for an average primary care practice, I don't know if anyone on the line knows, but I'm going to say they're between $1,000 and $2,000. So if I had good tech and had proven it out on the comm side, and I could give you as a primary care practice a 20% revenue lift, I think I can pay for the conversion costs and bury it because I know that I've got a buyer in the future, so I can capitalize that from the. But it is Nick. Nicholas, I don't want to underplay your point. I'm just saying it's probably on the order of $1,000 to $2,000 per practice to take a legacy practice and port the data over to a modern comms practice. So, yes, you're going to have to learn if you're a practicing MD, you're going to have to learn a new tech. Is there anyone who's practicing today who is not having to learn new tech this week? Wouldn't it be easier to learn good new tech rather than shitty bolt-on new tech added to a shitty record system that you've never liked anyways? Like, not learning new tech is not an option in the month of May 2020. So do you want to learn good new tech or do you want to learn terrible new tech? Can I do Zaina's question? Fee for service? Okay. Fee for service is a Pareto optimal solution that the ministry and the OMA can't get away from. They're like the cartoon dog and wolf who check in. Hello, Ralph. Hello, Fred. They check in the morning. They beat the crap out of one another all day long. And then they say, goodbye, Ralph. Goodbye, Fred. And they leave. They're stuck in a space. And everyone on both sides of the equation knows that it's terrible and that they have to stop it. And no one can agree on how to stop it. So let's take a trivial example. If right now, and I don't know what the current number is, when I was a negotiator, the lowest code to do a prescription for a walk-in visit was $17.40. Okay, so if it's $17.40 to renew a prescription, and I renew that prescription by email, what is the fair value under the fee-for-service system? Well, the OMA's position used to be $17.40, which is ridiculous. And the government's position used to be zero, it's not a covered service, which is ridiculous. So my answer, I don't know, call it $5 and have a nice day. But of course, the point is that paying doctors like vegetable pickers based on the number of bushels that they pick is wrong. And it's not serving doctors today because their income has collapsed as their visits have. And both the ministry and the OMA need to give their head a shake and get out of the trap that they're in and move beyond fee-for-service for this to work.
There's a question here about virtual care, which the adoption has been forced because there's been no choice, not adopted. So how do you see actual adoption playing out?
I agree with you, Maury. I'm just not sure. I've argued about this in multiple industries with a bunch of colleagues, and let me just play some of the arguments out. So one side is the point you're making, which is a great one. This is forced. This isn't voluntary adoption. Yes. But and I'll take it out of medicine. Yes, that's true. But the 72-year-old in the nursing home is still attending the Bloor Street United Church by Zoom and has figured out how to make Zoom work, even though she didn't want to. And she'd still prefer to go to church physically. But once she's learned that, will she in the future on days make a different decision? I prefer doing yoga in my studio with my yoga instructor, and I don't like doing it in my basement, which is what I now do 5 times a week. Will I still do it 2 times a week? Once it comes back online and I can do it physically, probably. Will they still offer the service? Yes. Will Maggie still offer the physical therapy service? What disruptive innovations general theory says, what Christensen says in the Innovator's Prescription, is that when a new attribute is introduced, usually people think about the disruptive innovation as being cost-based, which is why we called it cost of physical contact, to relate it that way. But really, what it is, the general statement of it is that a new attribute comes in that changes the buying habits. And that new attribute has always been there, okay? There have always been people who didn't want to come into the doctor's office because it took 4 hours. But they didn't have the option because the costs weren't recognized. Now that it's recognized, there will be stuff that's going on. Yeah, you know what though? Let me just also make the point. This is the 4th pandemic in 20 years. Most people are saying that this one's going to last I don't know, I heard numbers for a downtown office building saying that they're going to be at 10% capacity for June and July and 25% for August and September. I can't imagine the downtown office buildings having more than 6 people in an elevator much before October. So you are, how many of those practices, like, yes, they're being forced, but it's not like it's a short-term force. So I get, we can call it for, anyway, I'm wandering, and I'm sorry that I'm wandering.
No, it's great.
My basic point is that new habits are going to develop, new technologies are going to develop.
I think also from like a clinician's standpoint is that they're also recognizing going back to the clinic, it's much more expensive now with the purchase of all the PPE and like additional supplies they need. And it's just not feasible for some.
Yeah, well, and Duncan makes an interesting point around, Duncan's a surgeon. You know, there's a lot of literature about the fact that clinicians don't love their current tech and their current mode of practice. So I think, you know, there's a lot of innovation going on. Again, maybe forced. I'll accept the point that it's forced, but how are we going to do that, and how are we going to go? How can fee-for-service docs, Keith is a primary care doc in Southwestern Ontario, access to their data on utilization? Well, I'll give a plug to my friend Adam Hutton, who runs Doctor Care. He produces a monthly report based on your OHIP tapes and is really smart. He has a couple of products. Matthew had the same question as Maury. What else? Yeah, so Zaina, the additional costs of contact behind risks and fear of infection. That's exactly right, right? I mean, we're going to have higher and lower costs of physical contact, and there's some stuff you're going to want to do in a low and medium, even in a low and medium cost of physical contact virtually. I mean, I think it's trivially obvious that script renewal for stable patients should be being done virtually, but hasn't been. That would be my example. Maggie, where else are we going here?
There's a question about considerations about the impact of a more sedentary culture and impact on healthcare costs. Generally, people are just moving less, and this is going to affect all of us physically and mentally.
Yeah, it's interesting. I mean, so first off, healthcare costs are down, right? Everyone knows that. No one knows how much they're down yet. The Mayo Clinic was reported yesterday by CNBC as projecting the Mayo made $1 billion last year. It's a not-for-profit, but its positive bottom line was $1 billion. This year, they are projecting a net deficit of $3 billion because revenues are down by, I don't know, twice that. So revenues for the Mayo Clinic are healthcare system costs. So I don't think that COVID will drive healthcare costs up. It may well drive health status down. That's almost, I think, I don't know. It would certainly be interesting to talk about. One of the things that Sasha Bacha and Jay Shaw are focused on in our forthcoming How paper is the impact on choosing wisely kinds of utilization issues, because there are a lot of people who are making the choice now not to get health care, and whether they need it or not is an interesting question. I've seen some very, very preliminary data suggesting, for example, that CTAS level 3 presentation of chest pain is down in emergency rooms. You wouldn't think that COVID would have caused a reduction in heart attacks, but it does appear from the preliminary data that it might be.
I think also, like, again, pulling from my physio experience and the conversations that we're having, is that there's also higher unemployment. So people have less income, and therefore they have less to spend on things like, could be physio, yoga classes, exercise, and things like that, which is down the line eventually going to affect them and upfront affect small businesses.
Yeah. There's a great point here that Mike is making about alternate solutions as a way of reducing costs of contact, and I think that that's right on. I would point out, Mike, that you're talking about a patient's home. I think far more likely is congregate adult living. I haven't seen good numbers on this yet, but my gut would tell me that a long-term care home probably generates on the order of one specialty visit for every 10 residents every day of the week. And so if I was an executive director in a long-term care or retirement home, I would be going back and asking the question, how do I, if I've got 100 residents and I'm going to do 20 visits a day or 10 visits a day every day of the week, how do I get a specialist to come in? How do I get a consulting cardiologist to come in and do all the cardiology visits? How do I reorganize the group practice so that I minimize the costs of contact for my residents? Because one thing's for sure, sending out 10 visits a day by Beck Cab to my local hospital ambulatory care clinic is not going to reduce the costs of physical contact. So I very much agree with you that running this in different directions is part of what I mean when I say we need to mix physical and virtual. And, back to the forcing question, I don't want to come across as being too evangelical about or too much of an advocate for some of these virtual modalities. I really do hate doing my yoga classes virtually. I really do. I really do hate the fact that my mom can't see her consulting specialists, of whom she has 7. At the same time, I've watched my mom's endocrinologist read her lab results to her every 6 months for her stable thyroid condition for the last 6 years on a visit that usually takes me 2.5 hours. And this last week, we did it one-on-one with a 3-way phone call, right? And so I think that there are established practices that will change as we start opening up to some of these.
Essentially moving to the hybrid model, right?
It's got to be hybrid. I know at least one hospital that has set a target of a minimum percentage virtual on a go-forward basis for all their ambulatory clinics. So they've said, I won't name the hospital or the target, but they've said, look, we want to reduce our ambulatory physical visits by this much. What could you do in your specialty? Which of your visits would be suitable to move to virtual so that we can get fewer people coming into our physical space? Or to ask Mike's question again, which visits would you be willing to do on an outbound basis? If in your specialty, we know that you've got 25 patients down at the Rivera site down the street, can we group those 25 patients and do them on a day? Maybe we could do some of the visits as a group class, right? If some of those visits are overlapping, maybe there are ways that we could train an RPN and have that RPN or PSW and be there with your patients while we're doing it. And there's a whole set of things that we can do here. That one, question, I know Zane is on the feed, this whole question of how the role of a PSW changes in a time when the PSW is the only licensed person who's going into the home, and whether they can become a communications focus for the consulting specialist and do some of, not all of, but some of the hands-on work.
Fantastic. We're going to just close out with some final thoughts, final pieces of advice from Will, and then we will head over to networking, which will be open until 1:30. And for those who are joining for the first time, there is networking. The way that it works is you're going to hit the networking button. You will be automatically connected with somebody else that's on this call, and you have 3 minutes to chat with them. And at the end, you can both decide if you would like to exchange contact information. So
Maggie, thank you to you and the team at TechTO for giving me the chance to go through the material. Thanks to folks for listening. I have posted the material on social, both Twitter and LinkedIn. If you follow me on either of those modalities and want to send me some thoughts, I'd really appreciate them. There's a group of us who are working on this and thinking about these issues. And I really appreciate live, feedback on it in terms of how we make this healthcare system work a little bit better during these tough times. Really appreciate you guys giving the feedback in the chat and the questions, and for listening today. Look forward to continuing the conversation.
Thank you so much, Will, for joining us, and thank you to everyone for attending. We're going to do the same, well, not the same presentation, but we will have TechTO Health next Thursday, 12 till 1, and you can head over to networking to meet others who are on this call. So thank you so much. Thank you, Will, again, and we look forward to seeing everybody next week.